4:15 this afternoon, so members, please attend. Reception this evening at beginning at 6:30 at the Farmhouse Lawn, which is somewhere around here. Look for a patch of grass and lots of happy people, live music, food and beverages. There is also an industry-sponsored luncheon, our industry partner Legally Mine, for a lunch and learn session. Proper use of legal entities for lawsuit protection and tax reduction. You see why I had to read that. That's free to attend. Space is limited. It's a first come, first served. You don't need to register, just show up. And I believe that's in the farmhouse kitchen. So without any further delay, we're going to get started with a scientific session. Gentlemen.
All right, good morning. We'll get going in scientific session 3. Our first speaker is Dr. Samara Lewis from University of Oklahoma, presenting on the retrospective evaluation of neutrophil to lymphocyte ratio in association with lymph node ratio in surgically resected colorectal cancer patients.
Thank you. My name is Samara Lewis. I'm a general surgery resident at the University of Oklahoma, and I'll be presenting our research on the retrospective evaluation of the neutrophil to lymphocyte ratio in association with the lymph node ratio in colon cancer patients. As everybody in this room knows, colon cancer is the third most common cancer in both men and women, with an estimated 151,030 patients being diagnosed in a single year. And within that, 5,250 will die in a single year from this disease. So with the importance of this disease and the prevalence, there's a strong focus on identifying prognostic factors that we can use. One area that has been immensely studied in all solid tumors, and specifically in colorectal cancer, is the tumor immune microenvironment. Now, I'm only going to highlight 2 different cell populations within this. This honestly could be a lecture within itself for all the research that they've done in this environment. But specifically for this talk, one area that has been identified is the tumor infiltrating lymphocytes, or the TILs. So these are your CD4s and your CD8s that are actually within this tumor immune response with the host that are actually penetrating the tumor. The function that these cells actually carry is their tumor recognition, and they're actually tumor destructive. Now, as they've continued to study this tumor immune microenvironment, you would think the immune system is basically destroying the tumor cells, but they've actually found that there's a counter to this, and there's host cells that are actually productive of tumor spread and progression. And when you look at these specifically, these are your tumor-associated neutrophils, or your TANs, and they actually have tumor supportive function. And when you have an increased population within your leukocytes, this is actually a marker of that you've had chronic inflammation from a tumor that was present. Their known roles have been identified to be tumor promotive. They are actually immunosuppressive of other immune function. They produce cytokines that are actually encourage the tumor to progress, and they have suppressive function against those cytotoxic T cells we already discussed. With all of this information on the clinical side, there's been a drive to try to identify what kind of prognostic marker could we collect from the preoperative CBC. Areas that have been studied specifically in colorectal cancer include the neutrophil to lymphocyte ratio, the platelet to lymphocyte ratio, and the neutrophil to platelet ratio. Now, of all of these ratios that have been studied within colorectal cancer specifically, the neutrophil to lymphocyte ratio actually carries the most promise. And this is likely due to those populations that I've already previously highlighted. And when you have an increased ratio, this is a marker of deterioration of your cell-mediated adaptive immunity. And you're actually getting a swing in your leukocytes that's favoring tumor progression and spread instead of destruction. This ratio is a simple calculated from your differentiated CBC with absolute neutrophils divided by your absolute lymphocytes. Now we take this with what we already have known and established in colorectal cancer. We have this post-operative immune prognostic marker, and that's your lymph node ratio. This is the number of total positive nodes in your entire lymph node yield. This has been well established throughout the literature. This is directly correlated with overall survival, disease-free survival, and metastatic disease. This is just one of the published hazard ratios that are out there. And as you can see represented by this blue line, when you have an increased ratio, there's a direct drop off in your overall survival, not only in overall survival that's represented on your left, but also in disease-free survival. Okay, and then this is the graph that's going to represent your lymph node ratio. And as you can see, there's even a more significant drop off in your overall survival when you have that post-operative increased lymph node ratio. So the goal of this study, there was a lot of information just to try to highlight why we thought this was going to be important. So we wanted to see if this preoperative neutrophil to lymphocyte ratio that's been known to be associated with survival could possibly be associated with this lymph node ratio that we know correlates with survival. And then we also wanted to look at what specific cancer factors are directly related with this neutrophil to lymphocyte ratio. To answer this, we used our in-house Stevenson Cancer database. We limited this study to adults only with colon cancer who underwent a surgical resection. They had to have a CBC that was in 6 weeks of their surgical resection. We defined for this study a neutrophil lymphocyte ratio increase of greater than 5. And patients were divided into 2 cohorts, those with an increased ratio of neutrophil to lymphocyte and those with non-elevated. We only included patients with a minimum of 12 lymph nodes to prevent understaging, and our cancer-specific factors were histology, chemotherapy, pathological TNM stage, and lymph node status. I'm going to kind of click through our analysis and we'll go straight to the results. So these are our 2 cohorts. For our neutrophil to lymphocyte ratio non-elevated, we had 313 patients, and then we had 124 in those that had elevated. When you look at our demographic factors between the 2, there was no significance between the 2 groups. So I feel like they're fairly comparable. When we then looked at our cancer-specific factors, we found that the unadjusted significant difference was in the systemic chemotherapy with timing of that administration of chemotherapy. And then interestingly enough, also tumor size. We had an increased tumor size in the patients that have an increased neutrophil to lymphocyte ratio. But even on our unadjusted analysis, as you can see here, there was no difference in the lymph node ratio. When we then performed our multivariable analysis of the increased neutrophil to lymphocyte ratio for these cancer-specific factors to see what might be associated, one of the strong associations was pathological stage. And as you increase in your stage, that strength of association is increased. Chemotherapy continued to have a significant impact, and then lymph node ratio did not have a significant impact on this increased neutrophil to lymphocyte ratio. Now, when we performed our logistic regression, we found that there was no significant association between the lymph node ratio and neutrophil to lymphocyte ratio. This is just a scatter plot matrix for you to have a graphical representation of the association between the 2. And unfortunately, as you can see, there was no direct correlation. So in conclusion, pathological stage was found to have a significant association with an increased neutrophil to lymphocyte ratio and its increased strength of association at higher stage of disease. Tumor size did not correlate with neutrophil to lymphocyte ratio, and we highlight this because that is directly associated with lymph node ratio increase ratios. And then the lymph node ratio is not associated with the neutrophil to lymphocyte ratio within this data. So this highlights that even though the neutrophil to lymphocyte ratio consistently correlates with overall disease-free survival, that this is independent of those other common prognostic factors that have been identified within the literature. Thank you, and I'll take any questions.
Yes, sir, here in the front.
Hello, Samara. Is it working? Okay. Very nice presentation. Thank you very much for sending me your manuscript well ahead on time. It's a pleasure and an honor to discuss it. So we know that there is association of NLR, as you showed, with stage 3 and 4 colorectal cancer, and has been shown in retrospective papers, in meta-analysis, so there is some good evidence about it. And as you saw, there's quite a few clinical indexes that have been used, and I would like to congratulate the authors for looking actually into a potential mechanism, not just an association with improved survival. And that this paper is in the same line with other papers that shows no correlation of NLR with CA levels, tumor size, time to liver mets. And it doesn't seem that the NLR affects the outcomes for colorectal cancer, at least through a decrease in lymphocyte-mediated immune response. Any association of the NLR with patient comorbidities and frailty? I mean, many people believe that it is a marker of the overall health status of the patient. So I was wondering if there is any association with frailty. Since you have the data for these patients, you can check that. How did you? So some patients that they had multiple CBCs, how you selected the one to use for the study? Now, with regards to NLR and tumor characteristics, any association with LVI, lymphovascular invasion, differentiation? And then most studies show association of NLR with overall survival and disease-free survival. Were you able to assess this in your data set? And lastly, your multivariate model, should the outcome of the multivariate model be the elevated lymph node ratio more appropriately to look what factors actually correlate with elevated lymph node ratio, since this is what your variable of interest. Thank you very much. Excellent presentation.
Thank you. Okay, so I'll start with the frailty and the comorbidity. So this is actually a second branch of research that we've looked in this. The actual first time we looked at lymph node ratio was in the NCDB database. The reason we used our in-house database for this specifically was so that we could have the PATH and the preoperative labs that don't exist in the large national cancer database. We actually did an analysis looking to eliminate comorbidities and found that that lymph node ratio correlation still exists even in patients that have no known comorbidities coded in that NCDB database. So I haven't looked at specifically to see if that ratio is increased with them, but that data would suggest to me that that association still exists even in patients that don't have those increased age and increased comorbidities. The next question, I know that you asked specifically about lymphovascular invasion and perineural invasion, which was specifically what we were looking for too. Unfortunately, this specific data was limited it was the NCDB coding from our registry to be uploaded, and not all of that was included within our data. So we didn't have enough patients to actually pull significance. We're going to need to pull more patients to see the perineural invasion and lymphovascular. But I do think that's relevant because obviously there's something that's correlating with overall survival that we didn't identify within this subset for this. And then you talked about the...
Check the overall survival and disease-free, progression-free survival in your data set?
We could. We did not, though, but we could. We do have the data now.
Okay.
Yeah.
Thank you very much.
Thank you.
Well, I did fail to mention that's one of our Jack Barney finalists.
Sorry, come on up. Next up, we have Annika Kay presenting first steps toward implementation of a brain injury guideline across a 24 hospital system.
Too tall for this. Thank you for the privilege of the podium. It's an honor to be up here. I have no disclosures. So traumatic intracranial hemorrhage management is resource intensive, often mandating a hospital admission, a repeat CAT scan, and a neurosurgery consult. The brain injury guidelines, or the BIG, are a validated risk assessment model based on the risk of hemorrhage and the need for neurosurgical intervention, designed to standardize the classification and the management of hemorrhage. The BIG reduce excess resource utilization in a subset of lowest risk patients who may not need a hospital transfer or admission, a CAT scan, or even a neurosurgery consult. The original BIG were published in 2014 and classify patients into one of three categories, based largely upon clinical presentation, presence of pre-injury anticoagulation, and radiologic findings. They also dictate a management plan for each category. So a BIG 1 patient can be observed in the ER without a repeat CAT scan or a neurosurgery consult. BIG 2 patients are admitted for 24 to 48 hours of observation, but without a repeat CAT scan or a neurosurgery consult. And BIG 3 patients can have all of the things. It's important to recognize that a patient who's a BIG 1 or a BIG 2 on admission or on presentation, if they have a neurologic change, that automatically escalates them to a BIG 3 for all of the things. The modified brain injury guidelines were published in 2018 and recently validated last year. They aimed to refine the original BIG to enhance reproducibility, to improve patient safety. They removed aspirin from the anticoagulation list of significance, automating a BIG 3 score. They made all epidurals a BIG 3 regardless of size. They clarified subarachnoid hemorrhage measurement using number of sulci in millimeters. And they recommend a baseline neurologic exam prior to ED or hospital discharge. So as you're all probably thinking, this is a significant departure from the care of TBI at most centers, as it was at our center. So we aim to evaluate the feasibility and the safety of the modified BIG at our level 1 trauma center. We aim to identify system and site level barriers, all for the purpose of planning for a future system-wide implementation of the BIG across our 24 integrated hospital system, which includes non-trauma and trauma centers, of course. So we enrolled consecutive adult patients presenting to our level 1 center with traumatic intracranial hemorrhage and managed them using the MBIG. This was over 9 months. We also elicited qualitative feedback on the barriers to implementation of this protocol from multidisciplinary leaders via emails, meetings, and then a pre-implementation survey. We analyzed only big 1 and 2 patients, given that they represented the paradigm shift in management. Patients could have concomitant injuries, so they didn't have to be isolated head. And they were all evaluated by the trauma service in the ED, regardless of ED disposition. Our primary outcome was neurosurgical intervention. Secondary outcomes included ED disposition, repeat CAT scan, and neurosurgery consult, all of which went into our protocol adherence rate. We also looked at hospital length of stay, 30-day readmission, and then the identified barriers to a system-wide implementation of this process. So overall, just combining the 2 groups for big 1 and 2 patients, we looked at 87 patients who were middle-aged, 55% male, all suffered from blunt trauma, moderately injured, GCS 14.8. 60% were, or 59% were isolated head. And of those patients who were transferred to our center from outside hospitals, the majority were isolated head. Looking at our outcomes, no patients received the neurosurgical intervention. Of the isolated TBI, big 1 patients, 74% were safely discharged home from the ED. And of the a quarter that were not, only 1 was deemed a deviation of protocol. Repeat CAT scan occurred in about 16 and 18% of big 1 and 2 patients, respectively. Some of those were deviation of protocol. A couple had neurologic decline, and then also was for the indication, or the indication was for initiation of chemoprophylaxis. A handful of neurosurgery consults were obtained, and those were primarily deemed a deviation of protocol. So overall, our adherence rate to the protocol was 91%. Most of the deviations occurred early on as expected. Looking at our provider feedback, we ended up actually really focusing on the ER providers. So it's important to recognize that the BIG originally was designed to shift care of TBI patients from neurosurgeons to acute care surgeons. But with the application of the BIG to disposition and transfer decision-making, it now really shifts care to the ER side. And so the feedback from them was, number 1, radiology reports are inconsistent. So how do I calculate the score? Number 2, what are we doing for TBI screening? What's the role for therapy? Essentially, what are these patients who I would have admitted? What are they missing if I'm sending them home? What's the follow-up? It's unclear. Telehealth access is currently limited for trauma within our system. And then smaller hospitals were concerned about the resources for the ED observation period recommended for big 1 patients. So our single level 1 center pilot found that the BIG is feasible and safe, similar to other reports. No big 1 or big 2 patient underwent an intervention, and none had a readmission related to their TBI. The majority of isolated big 1 patients were actually transferred from outside hospitals, and the majority were discharged home from the ER. So as you can see there, there's room for improvement in terms of resource utilization. Overall, our protocol adherence was high, and we largely attribute that to the involvement of the trauma team in all of these patients, regardless of their ED disposition. We saved 72 CAT scans, 20 hospital admissions, and 83 neurosurgery consults over 8.5 months at a single center. So just imagine the impact if this were applied on a broader scale. And then most importantly, in my opinion, the pilot supported the creation of a multidisciplinary team for the purpose of system-wide implementation, which is planned for 2024. This is led by the emergency room and trauma surgery services. Also, we have a radiology task force who have developed a template to ensure that all radiology elements are included in reports. We have neurosurgery support. We have a PM&R task force working on identifying best practice of TBI in the ER, and also the role of PT and OT. They're also working on improving access in our rural communities to PT, OT, and concussion clinics. We're working on developing a trauma telehealth program. We're also engaged with our primary care colleagues who are often the initial follow-up site for these patients. And so it's important that they're aware that, we are foregoing CAT scans, and, they're aware of the BIG. And then we're working with a team of implementation scientists to assist in the methodology of our system-wide rollout. Thank you. I hope Sean was here because he told me to put this up here.
Very nice. Our invited discussant is Jordan Weinberg from Creighton Phoenix, and this paper was an APP award finalist.
Good morning. I congratulate the authors on their presentation and their very well-written manuscript. The brain injury guidelines were originally described almost 10 years ago and were recently validated in a AAST multi-institutional trial where nearly 30% reduction in resource utilization, namely CT scans and neurosurgical consultations, was observed. The modified BIG guidelines, or MBIG, was proposed by Kahn and al., which modified the original guidelines, the most notable of which was the upgrading of all epidurals to BIG level 3. And although the BIG and MBIG guidelines have been validated in level 1 and 2 centers, they have not been prospectively validated in lower trauma level or non-trauma designated hospitals. In this study, the group from Intermountain have described in detail a pilot project where they applied the modified BIG guidelines at a level 1 center to evaluate feasibility and safety, with the particular goal of identifying potential system and site level barriers to help plan for a hospital system-wide implementation of MBIG that is beyond the confines of level 1 or level 2 trauma centers. So I have a few questions for the authors. Among the BIG 1 and BIG 2 patients who were transferred into the level 1 center, did you encounter any patient or family pushback regarding the fact that they were not going to see a neurosurgeon, they were not going to get another CT scan, and perhaps they were not even going to be admitted? Second, one of the arguments for using BIG in a level 1 or 2 trauma center is that it reduces the cost of care, fewer CT scans, fewer neurosurgical consults. But it's not clear to me that employing the BIG guidelines across a system leading to potentially less transfers to a level 1 or 2 center will necessarily help the system. These patients tend to contribute positively to contribution margin at the level 1 or 2 trauma center. And then there's also the question of bed resources, where it's not only the level 1s and 2s where beds are in short supply, keeping these patients at a rural hospital may be actually difficult for the same reason. So has your hospital system attempted to make any cost savings projections for the implementation of MBIG across the entire system? And could it potentially hurt the contribution margin of the trauma service line at your level 1 center? And lastly, a philosophical question regarding implementation of MBIG across a system. You know, it's incredibly rare, but we've all seen the case where a BIG 1, or maybe more likely a BIG 2 brain bleed, blossoms into something quite worse. And when such a patient is being managed by the BIG guidelines at a level 1 center, you know, neurosurgery is immediately available. But if this patient were to be managed at a hospital without neurosurgical coverage, then there's an inherent delay to transfer to a level 1 center with neurosurgical care. And that could hypothetically result in kind of a disastrous outcome for the patient. So my question is, do you think the providers at hospitals in your system, in rural centers, smaller centers, without neurosurgical coverage, are going to be comfortable keeping these patients, particularly the BIG 2 patients, without neurosurgery within arm's reach should things go south? Thank you.
Thank you for your questions. I appreciate that. So the first question about what did our patients think? I will say we had zero pushback for patients who were admitted either with BIG 2 injuries or who had a BIG 1 head bleed that needed admission for either their TBI or for something else. We just kind of told them the plan and they were like, okay, I think the patients who had the most questions were the ones that were transferred to our center, only to be told, well, you didn't need to be transferred. And that's understandable. We would always offer those patients admission, but they were like, well, we don't want more. We want, so I think that, the disconnect between what we were doing and what the transfer centers were doing, obviously, I think that's where patients kind of, felt it and, noticed the inconsistent practice. Regarding the contribution margin, so our system includes the payer, so the cost savings positively impacts the overall cost of care. It's not really robbing Peter to pay Paul, at least how our system works. And really the shift from fee for service to fee for value, where reimbursement is based on quality of care, I think that shift will change the discussion. And really the BIG is actually a case where capitated care makes sense conceptually. I think it's really patient-focused, patient-centered. I think, putting the patients first, keeping them home because the data suggests that that's, safe for a subset of patients is really at the core here. We are in the process of making a cost savings analysis, and part of our implementation will include a financial impact analysis. And so we're looking forward to that. Bed availability. So yeah, it's a good point. There are limited hospital beds across the system. However, we're focusing initially on the BIG 1 patients who might not even need to be hospitalized. And so, that's the lowest hanging fruit, right? So can we reduce interfacility transfers? Can we reduce hospital admissions? And so that's kind of what we're focusing on initially. But remember, it's not only hospital admissions, it's also repeat CAT scans, it's neurosurgery consults, and it also has implications for shorter lengths of hospital stay, fewer ICU admissions. And so there's a lot of resource utilization that can be improved. The philosophical question is always an important one. And what I tell our ED medical directors across the system is, let's look at the data. You know, almost 10,000 patients have been reported or have been, looked at using the BIG, and about 2,400 Big 1 patients have been described, and an N of 0 have had a neurosurgical intervention. So that's pretty solid. I think for Big 2, that's a gray area. There are a handful in the reports who have required a neurosurgical intervention. All have had an associated neurodecline. So the guideline, protects those patients and escalates, them up to a Big 3. However, the distance from a neurosurgeon certainly matters. So we're not quite sure yet how our system is going to handle isolated Big 2 patients. We do have a teleneurology health program who actually currently is recommending observation at local facilities for Big 1 and 2 bleeds, although not using that language, but it's, we've looked at our data retrospectively and it's being, done. So, but yeah, Big 2 is kind of a question mark in terms of what do we do with those. So thank you.
Questions?
Good morning, Eddie Cornwell, Washington, D.C. I rise to compliment you on the presentation was wonderful. Its relevance is just extremely important across the board. A couple comments and a question. For those of us old enough to remember, the original evidence-based guidelines for trauma was for traumatic brain injury, much more severe than these. They had to be comatose, a different magnitude of care. They were all getting intubated. Some got intracranial pressure monitors. Neurosurgery was involved. But for every one of those patients, that's the tip of the iceberg. You have your patients. Many of us have maybe 1 or 2 committed neurosurgeons, and we're trying to do the best to keep them, preserve them for those patients for where they're really needed. So this is important work. And I think every paper that is published that says, here's several more thousand patients with this criteria that were managed without a single deterioration is an important paper. Papers, there's a place for papers where there's not expansion of injury. My question is the next step. These patients that are taking anticoagulants, antiplatelet agents, we have an active aging population. 80 is the new 50, so forth. And we're admitting a lot of patients, fall and bump their head, Glasgow 15, extremely great historians, caring family, keeping them in the hospital 12 to 24 hours for a second CT. I tease our residents now, it's become so commonplace, they don't even ask the patient the critical question, when did you last take your Eliquis? So the allegation of taking anticoagulants becomes a reason for a further admission. In your population, tell us do you know how many of your patients were on antiplatelet agents, anticoagulants, and are you positioned to help within your region to expand this to larger numbers? Because we need tens of thousands of patients without problems before everyone will be comfortable saying we can preserve our neurosurgeons for all these patients. Congratulations on your work.
No, thank you for that. Because we only looked at Big 1 and Big 2 patients, there were no anticoagulation medications with the exception of aspirin. At about 16% of our patients were on pre-injury aspirin. And actually they made up the majority of patients who had repeat CAT scans. I think probably because the provider was uncomfortable. And looking at all of those CAT scans, 0 of them had a progression of hemorrhage on their CAT scan and had no neurologic decline. It's a small sample size, obviously, but yeah, we had some aspirin patients.
All right, we'll take one quick question.
Okay. Nice presentation, Dr. K. Hoseinpur, University of Arizona. I'm trying to not be biased by modified big and big. So just the question is, you are presenting data that your data says that no readmission and no neurosurgical intervention through Big 1 and Big 2. So already big guidelines is validated on multi-center study, and they said that there is no neurosurgical intervention and readmission as well. So I guess my question is, these changes that you made on like anticoagulation and this stuff, so we presented the study that we showed that all this anticoagulation increases the risk of progression and neurosurgical intervention. My question is, what is the rationale behind modifying something that is already validated? And also, all this anticoagulation can increase the risk of bleeding. So what's your thought on this?
Well, I think you're referring to the modified brain injury guidelines who made the modification with removing aspirin. That was a multi-center trial just published last year. There are a couple other papers that looked at removing aspirin from the anticoagulation list of significance. We didn't really touch any of the other blood thinners. It was just aspirin. But we felt that based on the data, including this multi-center trial, that we would proceed with removing aspirin. We have been looking at our aspirin patients closely, but so far, we felt that was an appropriate change. To answer your question. Okay. Thank you.
Yeah.
Excellent. Very nice. Thank you.
Thank you. All right. The next paper is on the door to angio time as a matter, immediate angiography and decreased in hospital mortality of trauma patients by Dr. Yamamoto from the University of Texas.
Hi, I'm Ryo Yamamoto. Actually, I'm currently working as a trauma surgeon in Tokyo, Japan. I did a trauma fellowship in UT Health San Antonio. So I would like to say thank you to Southwestern Surgical Congress for giving me this great opportunity to have this presentation at the podium. So today I will be talking about the immediate angiography and the decreased in hospital mortality of trauma patients. Okay, let's see. This one? Okay. So we don't have anything to disclose. So angio has been a hemostatic procedure for trauma patients, and American College of Surgeons recommend the angio should be conducted within 30 minutes to 60 minutes after the indication of the angio is determined. However, a survey on US trauma centers reported the preparation of angio usually required 30 minutes to 2 hours in half of the facilities. And also the clinical benefits of the angio within 30 to 60 minutes after the indication remains unclear. So to eventually define the clinical important time threshold for the emergency angiography, we aim to elucidate the benefit of immediate angio that is defined with the one with the dual angio time less than 30 minutes. So this time definition is a little bit different from the ACS recommendations. That is the time between the indication to the needle time. But this study, we defined the time between the hospital arrival to the initiation of angiography because we don't have any time for the indication determined. So we used the Japan Trauma Data Bank. This is a nationwide trauma data bank, including the patients between 2019 to 2020. And this data bank included more than 250 tertiary care centers, which represents more than 80% of the trauma centers in Japan. So we included patients with who underwent non-operative management and also underwent angio within 12 hours after hospital arrival. So we didn't include the patients who were transported to the OR directly from the ER. So as outcome, we analyzed the in-hospital mortality and also the frequency of non-operative management failures. So we divided the patient with immediate angiography, that is dual angio time less than 30 minutes, and the other patient who didn't underwent immediate angio. So obviously the patient background of these two populations are different. So we use the inverse probability weighting analysis using propensity score to adjust patient's background. So the background included age, mechanism of injury, comorbidities, pre-hospital resuscitations, vital signs on arrival, and injury severity such as AIS and ISS, and also transportation time. So this is kind of busy slide, but this is patient characteristics. And left 3 columns are data for before adjustment, and the right 3 columns are data for after the adjustment. On each 3 columns, the left side is the patient for immediate angiography, and the middle one is the data for patient who did not undergo the immediate angiography. And we compare the data between two groups using the standardized difference, and in which the more than 0.2 should be considered as moderate to see a big difference. So if you look at the data before the adjustment, the higher systolic blood pressure and also lower ISS was shown in the patients who underwent immediate angio. That suggests the patients who underwent immediate angio are less severe than those without immediate angio. After the adjustment, you can see the biased distribution in variables got even with the adjustment. So the median time for of the Duarte angio was 22 minutes in a patient with immediate angio and 1.5 hours for the patient without immediate angio. So this is the outcomes. So in-hospital mortality was 5% on the patient with immediate angio, less than 30 minutes, and 11% for the patient with non-immediate angio. And also the frequency of the non-operative management failure, including thoracotomy, laparotomy, and laparotomy as damage control surgery. All frequencies are less in patients who underwent immediate angio compared with those without immediate angio. And so this is a cubic spline curves for log odds for the survival, depending on the Duarte angio time. So the higher number indicates the likely to survival, and the lower number indicates the less likely to survival. So you can see the decreasing trend of the probability of survival along with the prolonging Duarte angio time. And also the trend is changed around 90 to 100 minutes. So immediate angio should be conducted at least less than 90 to 100 minutes. So as conclusions, in Tram patients who underwent angiography within 12 hours as non-operative management, Duarte angio time less than 30 minutes was associated lower in-hospital mortality and also with fewer non-operative management failures. And also the angiography as soon as possible should be ideal. Thank you.
Thank you. We have Chad Hall from Baylor Scott & White, who will be our invited discussant.
Thank you. I want to congratulate Dr. Yamamoto and co-authors for a great paper and presentation. Thanks for sending it to me well in advance. This topic is pretty vital and relevant to American Trauma Centers, as DOOR to stick time is being recognized as a type 2 verification for ACS level 1 and level 2 trauma centers as of December 2022. So I do have several questions for the authors just to, one, help educate the audience about the practice of trauma in Japan. And then I want to help try to elucidate whether the immediate angiography was truly a life-saving procedure in these patients. So I have 3 questions. Number 1, can you describe the technical details of the angiography, who in Japan decides that it's indicated and who performs it? And then it was a little unclear, are these patients still getting contrasted CT scans, or is angio being used as a substitute for CT imaging? The second question I had, big limitation to the data set, and it's probably what was available in the Japanese Trauma Data Bank, but there's limited data on injury patterns, angio results, whether or not the angiography was therapeutic, and how many therapeutic interventions were performed. And then additionally, 24-hour or in-hospital mortality is, as we all know, is a poor predictor of hemorrhage-related deaths. And so how do you think your data would change if you cut that off at 24-hour mortality? And then as far as your non-operative failures, the damage control surgery, thoracotomy, and laparotomy, can you truly say that those procedures were a failure of the angiography, or could they have been, for a different injury that wasn't, a planned operation that wasn't intended to be cured by angio alone? Thank you.
Thank you, such great questions. So I'd like to answer one by one. So about the first questions, so the system for the angio in Japan is the technical aspect is very similar to the one in the United States, but usually it's decided based on the discussion between trauma surgeons, radiologists, and emergency physicians. So the the why the emerging physician is involved in Japan is very unique because we don't have not so many trauma surgeons in my country. So the emerging physician is usually involved in the trauma resuscitation. And also the angio can be done with radiologists or the emergency physicians who has a specialty training. So that is the reason why we can the angio so quickly. And also we use the same system for the myocardial infarction so that the cath lab can be prepared even before the patient arrival. So that's the reason why we can do the emergency angio is so quickly. And the second question is, I'm sorry, the first question. We always need a CT with contrast. So we don't substitute the angio with CT contrast. So actually the last year I couldn't make it because of the COVID, but I actually did the other study, the immediate CT scan, less than 10 minutes. It was also associated with lower survival and lower frequency of the no-blood management. So in Japan, we did a very quick CT with contrast, and also the following that, did a immediate angiography. That is my question for the first answer for the first questions. So the second one, so as you suggested, we didn't have details of the consequences of angio or details of the angiography itself, like which vascular is embolized or something like that. So that is definitely the major limitation of this study. So I adjusted all patient background that can be related to the outcomes of a trauma patient, but we couldn't adjust if that the data is lacking. So definitely this data should be validated in the prospective study or randomized control trial. And also the surgery, we couldn't differentiate the surgery that is kind of planned for the injury that cannot be treated, couldn't be treated angio or like a NOF error. But there's some cause for the surgery, and we can differentiate the surgery was a damage control surgery or not. So I would say if the surgery is kind of planned after the angio, that surgery should not be the damage control surgery because that can be very safe surgery. So the frequency of no-blood management, I counted that the laparotomy, thoracotomy, and also the laparotomy as a damage control surgery. So I think the number of damage control surgery is less in the patient with immediate angio. So I think that is that the fact can partly answer to your questions. Thank you.
Dr. Stewart.
Ronnie Stewart, San Antonio. I'm not an author on the paper, Dr. Yamamoto, so I'm going to make a comment. The first, thanks for coming to present. Thanks for extending your work to Japan and the U.S. I think the debate over the criteria deficiency is, to me, muddies the waters in that I believe that criteria is very reasonable in that I think your data show that it can be done in 30 minutes, is extended to 60 minutes. And I would just posit just make the statement that if the patient is bleeding and the goal, and they're in shock, and the goal is bleeding control, I don't think anyone would argue there's epidemiologic data, some clinical data, and huge amount of anecdotal data. The quicker you achieve bleeding control, the better for the patient. And so to me, we use it, as you know, we use it as a bleeding control technique in unstable patients all the time. And that should be done as quickly as possible. And it makes sense that it would lead to improved survival if you do it. So thank you for sharing your work.
Thank you.
Actually, I have one quick question. So your door to needle time do you think that's maybe just a surrogate for time to diagnosis rather than just time to intervention? Because a lot of these delayed angios are going to happen if you don't have the diagnosis initially.
Yes, but sometimes the patient is completely hemodynamically stable and have like a spleen injury and a little bit extravasation on the CT scan. In that case, I don't know, maybe in some institutions, they don't go to the, angio in a rush, So, my data can show that can be the surrogate for the early diagnosis, but also like, the team dynamics to go to the angio, as soon as possible, something like that.
Thank you.
Thank you.
Next paper, Dr. Jonathan Gushing, talking about pre-hospital tourniquet placement and extremity trauma from the University of Oklahoma.
Hello. So my name is Jonathan Gushing, and I'm a second-year medical student at the University of Oklahoma College of Medicine. First, I wanted to say thank you to the Southwestern Surgical Congress for allowing me to come in and give this presentation. It's an incredible honor. I have no relevant disclosures. So emergency tourniquet use, or ET use, has been a controversial topic historically among the civilian population. But with recent conflicts in Iraq and Afghanistan, there's been a renewed conversation among the public. Oh, that was a bad button. Uncontrolled hemorrhage has been identified as a major cause of death and extremity trauma, and it has also been identified as preventable. So recent data has also suggested that pre-hospital tourniquet application improves patient survival by 11% when compared to tourniquet application after arrival at the hospital. So starting in January of 2017 in the state of Oklahoma, all certified first responders were required to complete a CLEAT training. And this included coursework for patient evaluation, wound packing, as well as stop the bleed programs for tourniquet use. And with the corresponding increase in tourniquet use has also come inappropriate use, placement, and a lack of documentation as a result. And a recent study actually found that nearly half of pre-hospital applied tourniquets were inappropriately placed with a subsequent harmful effect in 3% of their population. So the primary purpose of this study was to examine the effectiveness of pre-hospital tourniquet protocols in the state of Oklahoma. And we also had a secondary purpose of evaluating varying first responders and their protocol compliance. And we hypothesized that while the state of Oklahoma has pre-hospital tourniquet protocols in place, they're not routinely followed by first responders. So this was a retrospective review of prospectively collected performance data sheets from 2018 to June of 2022. And we also accessed data via EMS run sheets, EMR records, and trauma registry as needed. We split data into before and after ED arrival. And we also split ET appliers and compared them as one entity versus 3 as EMS, police, and other. So this is how we defined appropriate tourniquet placement. 1, if arterial bleeding was identified after removal of the tourniquet. If there was arterial or any significant venous bleeding identified on CT or CT angio, if there was near partial amputation of the limb, and if vessel ligation or vascular repair was indicated for the injured limb. So here you'll see the 3 groups that we looked at. In the blue, you'll see EMS, orange, you'll see police, and green, you'll see other. And as our study progressed from 2018 to 2022, we had an increase in tourniquet application by both the police and other groups, with a corresponding and proportionate decrease in the EMS category. Also keep in mind that 2022 is only through June here. So here is our injury characteristics. And so we split injury type into blunt versus penetrating. And within that category, we saw that police placed a statistically significant number of tourniquets for penetrating injuries. And among those penetrating injuries, 55% of those were due to gunshot wound. Also in the other category, they placed tourniquets for a significant number of injuries of the lacerating type. And this accounted for 50% of their indications. Specifically for the EMS, we saw that EMS managed more patients with ISS values that were greater than or equal to 16. And we also saw that they had the highest average at just over 11. And also for the EMS, they managed patients who had higher MES scores at just over 4. And we also hypothesized that this is because they managed more blunt or polytraumas. So here is, following those EMS values, we can also see that EMS managed more patients that were in shock per their systolic blood pressure or shock index. And also EMS managed patients who had lower average hematocrit values, and patients managed by EMS were more likely to require blood transfusion on arrival. So here's the tourniquet types that we looked at. And across the groups and overall, we saw that the majority were the CAT style tourniquets, about 3/4 of them, with the remaining quarter being non-CAT or makeshift style tourniquets. And we also looked at packing attempted prior to tourniquet placement, as well as if the tourniquet was adequately placed per there being a distal pulse being present, or if the limb appeared to be well perfused. And we saw that 1/3 of the patients had packing attempted prior to placement. We also saw that 1/3 of the patients had a distal pulse that was present, as well as we saw 1/3 of the patients had a well-perfused limb. A good thing that we saw was that tourniquet placement and removal time were both well documented across the groups and overall. And we also saw that there was statistical significant difference between the groups in their total tourniquet time, with the highest value being in the other group, and that was for just over 90 minutes. So emergency tourniquet use has been shown to be used with an increased frequency in the civilian population, and there's been a resulting lower mortality rate because of this. But also with increased use, there has been increased tourniquet use for inappropriate indications. And our study kind of reflects this. We saw 36.5% of our patients only had proper indications per our criteria. We also think that trauma surgeon indications and pre-hospital setting indications may differ in some part due to varying availability and resources, but further education is warranted. So this is a retrospective review of prospectively collected data sheets. So selection bias or missing data points due to poor documentation might have happened. This is also a single institution, small sample size. So we concluded that although tourniquet application has increased, placement protocol has not been routinely followed by first responders. And we also concluded, it's not listed here, that further education is warranted in order to minimize short and long-term negative outcomes. Thank you.
Very nice. Invite up Dr. Benjamin Axman from Sanford Health to as our invited discussant.
All right. Is this on? So thank you to the Southwest Surgical Congress and the authors for this opportunity. And of course, the opportunity to discuss or critique a paper that Dr. Albrecht's on. Congratulations on a great study and having the opportunity to present it at this conference, especially as a second-year medical student. You did a great job. So, you know, I think these kinds of studies are important. Anyone that works in the trauma bay, we've seen that patient come in with the tourniquet on, and they have, you know, palpable pulses, and everyone kind of feels like an idiot in the room. And tourniquets, like you said, were out of vogue. Now they're coming back in vogue, and especially with Stop the Bleed, we're kind of really pushing it. And so we're seeing them almost daily. You acknowledge there are studies out there looking at extremity tourniquets, especially, again, in the wake of Stop the Bleed. And we're actively studying and seeing the efficacy of our efforts with regard to Stop the Bleed. So we're seeing papers that show mortality and morbidity are improving with tourniquets, but then there's just as many papers out there that kind of show that we're either doing them in the wrong location, in the wrong location for the wrong reasons, or doing it the wrong way. And then a recent paper that you did include in your study showed that, you know, 51% of the tourniquets that were applied in that study were for the improper indication. So your study showed that too often extremity tourniquets are being utilized as the initial intervention. And then you stratified this based on who would place the tourniquets, which made your paper unique. And then, of course, I liked how you used prospectively gathered data and then reviewed it retrospectively. So the questions that I have, number one, how did you conclude whether packing was really used or not? Because I imagine all those patients came in with some sort of dressing in place. Did that count as packing, or I guess, how did you stratify them into being packed or not packed? Number two, you included makeshift tourniquets in your study. And we all know that makeshift tourniquets are going to be less effective. And then did you stratify those out? And if you did or didn't, do you think that would affect, or did it affect your results? And then lastly, one of the endpoints you looked at was presence of arterial bleeding on either CTA or on operative findings. Did you have patients with major venous injuries? And then if you did, were those patients categorized as improper indication? Again, thank you.
Thank you. Those are great questions. So the first question pertaining to packing was addressed either on the scene and documented by EMS, or it was verbalized on arrival to the ED. The second question, I can remember the third question. Third question, the makeshift tourniquets. Okay. So makeshift tourniquets were included, and that was included in the non-CAT style tourniquets. And so the majority of the non-CAT or makeshift style tourniquets were still commercial grade and still the same mechanism of CAT style tourniquets. And then the minimum, like the smaller proportion of that was true makeshift tourniquets, and those were usually belts, or I think in one case, a ripped off piece of shirt. And then concerning venous bleeding, we categorized major venous bleeding as such as venous bleeding from either the femoral or like brachial vein. And we had some cases that were minor venous bleeding, such as like superficial veins, but those weren't included as appropriate indications.
Thank you. Eddie Cornwell, Washington, D.C. Jonathan, I don't know if this is your first regional conference presentation, but if it is, your career is off to a great start. Congratulations, very nicely presented.
Thank you.
I think I share your view based on the tone and tenor of your presentation. I'm not a big fan in this setting. I'd make a comment and a question. I'm always careful that when the paramedics roll in, as your data show, the majority of these are gunshot wound patients, penetrating trauma. At the scene, you can only imagine how chaotic it can be, and they're reacting to seeing this blood around a whole lot of other onlookers who are seeing blood, and they're doing things that they've been taught in their past. So when I take that tourniquet off, the first thing I do and put my finger directly on the site of bleeding, I go to great effort to make sure that's not perceived as in any way casting judgment on them. They're working by protocols that they were given. But I've always said for decades now that I'd rather have a medical student working with me and two educated fingers on the wound rather than a tourniquet. Venous bleeding gets worse distal to the tourniquet site, which brings me to my question. I think in your introductory comments, you said 3% in prior reference, 3% of patients had some sort of deterioration. Can you tell us a little more about those, how that was determined and what it was, what sort of clinical setting, or what was the clinical deterioration?
So in, I think that specific study, there were mainly long-term outcomes such as like rhabdomyolysis or like chronic kidney injury or major kidney injury due to issues with the tourniquet. I'll be honest, that's all I remember about that study off the top of my head.
Dr. Campion.
Eric Campion from Denver. So I applaud you on your study. This is a fantastic topic and super important. And we are also seeing in Denver a significant overuse of tourniquets. I think there's no doubt that that is occurring. I would caution, though, trying to evaluate retrospectively what was an appropriate or inappropriate use of the tourniquet is really quite difficult, because obviously if there's a major vascular injury, there's a good chance that that was an appropriate use of a tourniquet. But we've certainly seen a number of degloving and other large injuries that have significant bleeding that would not be classified as a major arterial or even a major venous injury that really I would feel is probably an appropriate use of the tourniquet. And then also, I just, for the audience, I have an EMS background, and I think one of the things that sometimes gets lost is while direct pressure and wound packing is by far a superior method if it's effective, oftentimes in the ambulance, there may only be one provider in the back of the ambulance. And if they have their finger on something, they can do literally nothing else. And every bump, their finger pops off of it. So I think you have to be a little bit circumspect just about the circumstances that are sometimes undergone here. And so I don't want to, denigrate the use of tourniquets in these situations, but I agree with you and I agree with your study. We're seeing an overuse and we're kind of constantly re-educating our providers. So that's just a comment I wanted to make. Great study. Thanks a lot.
Thank you very much.
Ronnie Stewart, San Antonio, terrific presentation. As somebody who's taught a very large number of Stop the Bleed, American College of Surgeons Stop the Bleed classes, it's a little disheartening, I will say, because a lot of things you're talking about are not or go counter to Stop the Bleed education training, no improvised tourniquets, direct pressure, assess the severity of the bleeding. I think the issue, though, is having taught a bunch of the courses, is there's different communities, I'll call them communities of interest. So there's the lay responder, there's EMS, which are medically trained first responders, and then there's police. And in that subset, there's a group of tactical responders. I think a lot of the aggressive tourniquet use comes from the tactical side. I think you're far more likely to see immediate tourniquet use and to use the high and tight method. Put it as high and tight, which honestly doesn't make sense to me in a civilian setting. So I would say really good work. In the next iteration of Stop the Bleed education training, there is going to talk about when to take the tourniquet off, and I think more emphasis on when it's appropriate. But my question for you is, what's the next step in your system? Because I think we could all benefit from education, particularly to police would be but I'm just interested in what y'all think with respect to that. What's your next step in improving the system? What's the next step from this data?
So specifically for Stop the Bleed, for an example of this project, we had quite a few injuries that had, say, a wrist injury, and the tourniquet was applied up here. And,
high and tight method.
And so we had quite a few of those. It was technically placed correctly, but how correct is that? And then also we, on average per our data, police were the first on the scene, and they also managed the most gunshot wounds. And so one thing that we considered was the fact that police were not just managing the wound, but also possibly a scene where there was still gunfire being actively involved. So that is something that might have been masked in our data as well. But for Stop the Bleed programs, I would definitely hope to see an improvement in patient assessment and actually deeming if a tourniquet is appropriate for specific injury, as well as the importance of packing, because packing was something that was relatively lacking in our data. Thank you.
All right, thank you very much. Next up is Daniel Nguyen to discuss resuscitative endovascular balloon occlusion of the aorta, or REBOA, for interfacility transfer. For this one, we will, in the interest of time, we will limit the discussion to our invited discussant.
Good morning, ladies. Good morning, gentlemen. My name is Daniel Nguyen, and I am a second-year medical student at Creighton University School of Medicine over at our Phoenix Regional Campus. The briefing I've prepared for you today concerns the use of REBOA prior to the interfacility transport of trauma patients. As a bit of background, and as most of you know, hemorrhage is the most common cause of preventable mortality from trauma. Now, resuscitative endovascular balloon occlusion of the aorta, or REBOA, is a method to occlude the aorta within either zones 1 or 2 in an attempt to tamponade the blood flow and prevent any more hemorrhage distal to that balloon. Its first reported use was by Lieutenant Colonel Carl Hughes during the Korean War, where he developed it for the initial stabilization of any of his patients and his soldiers coming in suffering from major infradiagmatic torso hemorrhage. When we look at the geography of my home state, Arizona, we see a relative paucity of higher level trauma centers outside of the major cities. In fact, we only see level 1 trauma centers in 3 major cities. To the north, we have a facility in Flagstaff. In the central part of the state, we see the most number of level 1 trauma centers, of course, being in Phoenix. And to the south, we have a facility in Tucson. When we look at the population of Arizona, we have very many number of patients outside of these large cities and away from any urban center. In Arizona, over 500,000 patients live farther than 30 minutes from any hospital facility whatsoever, not even counting our trauma centers. Looking at just the trauma centers, 1.7 million of our population live in a location where their nearest trauma center is a level 3 or lower center. And studies have shown an association between the distance a patient lives from a trauma center and their mortality risk from trauma. Because of the geography and population of our state, we developed this study and our aims were twofold. One, to determine the number of patients initially seen at lower level trauma centers who die prior to their transfer and admission to a larger level 1 facility. And secondly, to assess which of these patients may have benefited from Reboa intervention. To do so, we made a query of the Arizona Trauma Registry over a 3-year period for any hypotensive patient 15 years or older seen at a non-level 1 trauma center who is then either transported to a level 1 trauma center or died in the emergency department of this referring facility. The data for each patient were collected in the form of age, initial vital signs, ISS, AIS codes, as well as their ICD-9 and ICD-10 diagnoses. We defined any Reboa candidate as a patient who, upon review by a couple of our faculty surgeons, saw that their cause of death was major infradiaphragmatic torso hemorrhage. We excluded patients with major extremity hemorrhage, head and neck and thorax hemorrhage, as well as solely a TBI injury. After a review of this database, we found that 347 of the patients met our inclusion criteria. 14 of these patients, we felt we did not have adequate information to determine their status as a Reboa candidate, leaving us with 333 patients. Of these patients, 28 or 8% of the patients were determined to be Reboa candidates, and 305 were determined to be non-Reboa candidates. Of the 28 Reboa candidates, 14 were due to pelvic hemorrhage, 9 due to retroperitoneal or abdominal hemorrhage, and the remaining 5 due to concurrent pelvic and retroperitoneal hemorrhage. Of these 28, 27 of these patients expired at the referring facility, and only 1 survived transport to the accepting facility where they eventually died in the emergency department. Of note, only 10% of these 28 Reboa patients had a comorbid TBI. Looking at the demographic and clinical characteristics of these patients, comparing the Reboa candidate and the non-Reboa candidate group, we see that there's no significant difference between both sex and age, and like most of our trauma population, they were primarily young males. There's also no statistically significant difference between trauma type or their ISS scores. Also of note, the mean Reboa candidate ISS was found to be 22.9. This, while high, was still generally considered a survivable injury severity score. Now, the limitations of our study mainly stem from the fact that this was a retrospective review of a database. This meant we were unable to do any in-depth chart review on each of these patients and unable to capture those granular patient specifics. Because of this, we were also unable to see if there are any potential alternative therapies to Reboa in each of these patients, such as pelvic binders that may also help for any pelvic injuries. So our conclusions were, looking at in Arizona, or the state of Arizona, which has a large population outside of these urban centers, a small but significant number of the patients injured outside of these centers die after arrival at their nearest hospital, but before their transportation to a level 1 trauma center. All of these patients did have ISS scores consistent with the possibility of survival if their nearest facility had been a level 1 trauma. So we concluded that Reboa may be an effective means to extend the survivability in up to 8% of these patients. Additional further considerations for further study We'll have to include the resource feasibility of a REBOA program implementation, as well as the training for the management of REBOA during transport, which is novel for an American EMS system, and the safety of REBOA use for these practitioners in these non-metro rural areas who may not have to routinely access the femoral artery. Thank you, ladies and gentlemen, for your time. And if you have any questions, I would be happy to address them.
Nicely presented. Now we have Dr. Latifi is our invited discussant.
Thank you very much. Thank you very much. That was a beautiful presentation, and thanks to Southwestern Surgical Congress for the privilege of the floor. I do want to thank Mr. Nguyen for sending me the manuscript on a very timely fashion, and congratulate Dr. Bogart's group for bringing to our attention very provocative yet creative idea that may potentially help reduce preventable trauma deaths from bleeding using REBOA. Finally, I would categorize this study as a push in the envelope, but we all need to do that. Both you and I and everyone in this room knows that death from trauma patient is multifactorial, but mainly a result of and/or consequence of injury, time spent from the injury to the hospital, and once they get there, by whom and where the patient were being treated. How do you separate all these factors? And saying they died because there was no REBOA available is a difficult answer to come up with. I think the manuscript, which, as I said, you send me in a timely fashion, will benefit from few additional data. And I understand the retrospective nature of the study, and it's very difficult to get all the information, but really how long they spent before they went to the ER, to the hospital, or as you're calling it, a facility. Who treated them? Did they have blood transfusion protocol? Did they receive any blood before they transferred, and so on and so forth? I have two questions for you. How many of these patients who died both at referring and accepting hospital had autopsy, if they did? And did you have a chance to review those? And you just said that you didn't really have a chance to review many details. And while you spent some time discussing the manuscript, discussing the complexity of maintaining REBOA expertise, how do you imagine training all of those who eventually may manage these patients at the lower level trauma centers? Need to take in consideration that there is a large flux of providers as well in rural facilities, rural medical centers. And do you think that we should all carry card of REBOA expertise, just like we carry an ATLS or ACLS? Thank you very much. And on a personal note, you definitely showed to us today that you have perfect DNA to become a trauma surgeon. So make sure you do that.
Thank you, sir.
Thank you.
Well, thank you, Dr. Latifi, for your comments and your very insightful questions. To answer your first question, which I believe was on the topic of the treatment of these patients and their receiving of blood at these accepting facilities. Yes, unfortunately, due to the limitations of the Arizona Trauma Registry, we do not have these specific data points. However, we can say that the hospitals contributing to this database have a very wide range of capabilities, from the critical access hospitals we see out in the rural areas to relatively well-equipped level 3 trauma centers. So for blood products, we see this ranging from no blood products at all to something that you would see at a larger hospital and larger facility. So these data that we looked at did represent how all of these patients are faring given the current standard of care at each of the facilities they were initially seen at. In regards to your second question, yes, unfortunately, we also do not have access to reports from the medical examiner on each of these patients, but we do agree that this would be helpful in better understanding this issue and better understanding each individual patient and whether or not they were or were not REBOA candidates. And as to your third point in the proficiency of REBOA placement, this is definitely a hurdle to overcome, especially here in the US. In Europe, we have seen, or there have been papers put out on the pre-hospital application of REBOA done by non-surgeons. So we do see that it can be done and it has been done around the world. How exactly they measure competence, we're unsure of. So that is definitely a hurdle to overcome. But we do know that there are future technologies simplifying the ROBOA process, which may widen the number of providers that may be able to use this intervention. And through those future technologies and perhaps integration into training systems such as ATLS as you managed, we could get a wider or more widespread use of ROBOA in these smaller facilities. Thank you, sir.
Okay, thank you very much. Thank you to all the speakers and discussants and questioners from the floor for an excellent session. We'll have a short break of 10 minutes, reconvene here at 9:30 for scientific session 4.